Well, good evening, everybody, and welcome to Cornerstone's Health Best of UEGW and ACG 2021, an update on IBD pivotal clinical trials. I'm David Rubin. I'm at the University of Chicago, and tonight I'm joined by three amazing colleagues and faculty for this excellent program. And actually, this is a repeat. Last year, for the first time, we did the Best of UEGW and ACG, and we had the same lineup of faculty, so we know it's going to be spectacular this evening. I want to introduce our faculty briefly to you. I'm joined by my partner in Cornerstone's Health and the co-founder of Cornerstone's Health, Marla Dubinsky, who is a professor of pediatrics and medicine at the Icahn School of Medicine. She's also the chief of pediatric gastroenterology and nutrition at the Mount Sinai Kravis Children's Hospital and co-director of the IBD Preconception and Pregnancy Planning Clinic at the Mount Sinai School of Medicine. I'm also joined by Sushila Dalal, who is at the University of Chicago with me. And Dr. Dalal is an assistant professor of medicine in the section of gastroenterology and one of our IBD specialists. We're also joined by Elizabeth Spencer. Dr. Spencer is an assistant professor of pediatrics at the Icahn School of Medicine at Mount Sinai. So we're really excited to share this with you tonight, and we want to acknowledge a number of other folks who have contributed to this program. In addition to the faculty I've already introduced, we want to give appropriate credit to our two colleagues in the UK, Peter Irving, who's at Guy's and St. Thomas's NHS Foundation Trust at King's College in London, and James Lindsay, who's a professor of IBD and a consultant gastroenterology at the Barts Health NHS Trust at the Queen Mary University of London. And they were also part of this program last year, and we're very grateful for the hard work they do to pull this together. We also, similar to last year, have a few clinical trial videos, and this includes presentations by Iris Dotan from the Rabin Medical Center in Israel, Mark Ferrante, who's at University Hospitals in Leuven, Belgium, and Remo Panaccione, who's the director of the IBD unit at the University of Calgary. And you'll see them presenting some of this work throughout our presentation this evening. Here's all the accreditation and credit designation. I'm not going to go through all this. It's also in your handout. But for tonight's program, you can get 1.5 AMA Category 1 credits. You can also get ANCC contact hours for our advanced practice nurses and nurse colleagues who have joined us tonight as well. One more point, you have to complete our post-program evaluation to get your credit, and you have to do it within 10 days. So please don't ignore that email so you can get credit, but also really because we love to hear your evaluations and to learn how we might improve this in the future. Thank you. We want to acknowledge the support for this program. This is a program that was developed by Cornerstone's faculty for you, but we do have unrestricted educational grants from AbbVie, Janssen Biotech, administered by Janssen Scientific Affairs, Pfizer, and Takeda Pharmaceutical. We will be discussing off-label or investigational information. That's sort of the whole point tonight, as well as some of our existing therapies that have been studied in the real world, et cetera. And of course, the opinions of our faculty are the opinions of our faculty and are not influenced otherwise. Okay, disclosures are all available. We also had a reviewer from the standpoint of CME and a wonderful partnership with a group that helps us accredit everything, led by John Junkowitz, and we're grateful to him as always. So at the conclusion of this program, we hope that you will be better able to incorporate advances in therapeutic options and understanding of biologics, small molecules, and biosimilars for the treatment of Crohn's disease and ulcerative colitis. Consider the implications for short-term outcomes in IBD based on clinical presentation and treatment strategy, and of course, identify risks and benefits of current and emerging therapeutic options for patients with IBD. So I'm going to start us off, and as we go through the program tonight, you're going to hear from each of our faculty as well as those videos that were pre-recorded. So let's talk briefly about the therapeutic targets and the pipeline in IBD. It's truly been an exciting time in the space of IBD, and there are so many new agents in development that in fact one of our biggest challenges has been appropriate design and recruitment into clinical trials. If you look at this cartoon that's meant to represent all the different targets and potential pathways for controlling the overactive or the constitutively active inflammatory response of IBD, you can appreciate the gut lumen and the potential for modifying the microbiome and other components of the environment there and the ecosystem in our intestines. You can appreciate the epithelial cell lining and the many components of both the cellular as well as the humoral immune system, with a variety of targets that already exist, as well as a variety of targets that are being explored. At the bottom of the cartoon is representing a blood vessel. And of course, we have ongoing studies and available therapies looking at inhibitors of leukocyte trafficking. And you can also see on the right what is supposed to represent a lymph node and the emerging therapies that have to do with prevention of egress of activated lymphocytes out of lymph nodes. And we'll be touching on many of these tonight. So you can see the available therapies that we have that are anti-TNF, of course, and you know those well. The therapies that have been studied and some that are available related to anti-integrin and leukocyte trafficking are anti-IL-12/23 inhibitor, Kinemab, on the market for both Crohn's and UC. A variety of P19 inhibitors that are targeting only IL-23, and we'll be talking a little bit about that tonight, and our 2 S1P receptor modulators or agonists that work specifically on that lymph node target. We also have, of course, a variety of JAK inhibitors, Janus kinase inhibitors, some that are specific to JAK1 and others that are less specific or are targeting different components of all of that. And we'll touch on some of that tonight as well. So quite a bit to talk about. Of course, this table summarizes the available options that are already approved by the regulatory agency in the United States and throughout other parts of the world. And you can appreciate the list of therapies here, including our 3 different classes of biological therapies, and now our 2 synthetic targeted small molecules, the JAK inhibitor tofacitinib and our first S1P receptor modulator, Ozanamat. Both tofa and Ozanamat have been approved and are available for the treatment of ulcerative colitis. Also on this table are the other indications that some of these therapies carry, just as a clue to other mechanisms, but also a very interesting and emerging area of understanding shared immune pathways across different diseases. And we'll touch on that a little bit tonight. Here's all the listed phase 2 and phase 3 trials that are ongoing, as well as the licensed therapies across different classes. We're not going to cover all of this tonight, I'm sure you understand, but it gives you a good overview of the very rich pipeline that is coming for IBD. I'm going to present a couple of abstracts related to Kinemab and adalimumab, and an additional abstract related to long-term follow-up in Kinemab, and we'll talk more about that. So these 2 abstracts, one was presented by our colleague Matthew Allais from France, the other by Silvio Danese in Italy. The Seaview study was our first head-to-head biologic study in Crohn's disease. This was a study in adult biological naive patients with moderate to severe Crohn's disease, and they were randomized to either Kinemab or adalimumab. As you can see on the left side of the schema, the patients received their loading doses of both agents. Remember, Usta gets a weight-based IV loading dose. Adalimumab is 160 milligrams subcutaneous. And then they continued on into the maintenance phase, where they received either the sub-Q injections of Kinemab or the standard dosing of adalimumab into its sub-Q maintenance phase as well. You'll notice that there were placebo injections or infusions that continued on so that the patients and the investigators were blinded. The primary endpoint of the study was at week 52, looking at clinical remission. So this has been presented in various forms and different parts of it over the last couple meetings, and we're still waiting for it to be fully published. But the bottom line of this first head-to-head biologic study in Crohn's disease was that there was not a statistically significant difference in clinical remission at week 52 between Kinemab and adalimumab. The hypothesis in the study was designed expecting Kinemab to beat adalimumab, but it did not. I'll point out to you that a 61% and 65% clinical remission rate with these agents is really quite remarkable and a lovely outcome in and of itself. Remember, these were bio-naive patients. So this is what you can get if you use the drugs early in our patients with Crohn's disease. Looking at endoscopic response on the right, you can see numerically a bit better with Kinemab, but there was not a statistical significant difference between the two. So of great interest there. Now, the study also included a variety of other analyses. In this particular part that we're sharing with you and presented at UEGW was the PROMIS 29 assessment of health-related quality of life. PROMIS 29 includes all the domains you see here: physical functioning, anxiety, depression, fatigue, sleep disturbance, ability to function socially, pain, and pain intensity, or how pain interferes with life. And they have a clinically meaningful improvement that was defined as well. So this is a measure you may not be as familiar with, but I'm sure that the symptoms and considerations that are listed there are of great interest to you. And as you can see across the board here, although for many of the different measures across the top domains, you saw some numerical benefit of ustekinumab over adalimumab. The only one that was statistically significant was in fatigue, interestingly enough, where Usta actually did better than adalimumab. And you can see across the bottom that the sleep disturbance was no different between the two, and assessment of pain or pain interference was no different, but the ability to participate in social functioning, interestingly, was better with ustekinumab. So that was new. Some of you had heard Seaview's outcomes before, but not this, I'm guessing. You can also see they presented some of the PK data related to these therapies. So we're always interested in understanding more about the pharmacokinetics. And you can see here the quartile analysis of serum concentrations of adalimumab and ustekinumab, looking at specifically here clinical remission. You'll note that with adalimumab, the higher serum concentrations was associated with more clinical remission. With ustekinumab, it was basically a flat line, although you might argue there's a little bit of benefit between the greater than third quartile and the less than first quartile. So that was of interest. But maybe of more interest is something more objective, endoscopic response. And looking at the final trough serum concentration quartiles, you can see a more obvious dose response here, with serum concentrations being associated with a greater likelihood of endoscopic response at week 52 for both drugs. Of great interest is this, which is looking at immunogenicity. Start on the right, ustekinumab has very low immunogenicity, and across the study, the first bar on both of these charts is week 16, the second one is week 52, and the third one is an antibody positive at any time assessed throughout the study. And you can see Usta basically was 0 or extremely low. And adalimumab, using a drug tolerant assay, had very high neutralizing antibodies, or at least antibody measurements. This was also associated with lower serum concentrations of drugs. So some of this was clearly neutralizing, but probably not all of it, because you're probably as surprised as I was to see how high this antibody level was with adalimumab. So clearly we're picking up a lot of antibodies. Some of them are obviously neutralizing because they were associated with lower serum concentrations, but it doesn't necessarily correlate completely to what we see clinically. Nonetheless, you can see the difference in these two therapies from an immunogenicity point of view. So that's Seaview. Now I'm going to present to you the long-term follow-up of ustekinumab for ulcerative colitis. And this is looking at the 3-year follow-up data. It was presented by Maria Abreu from the US, of course. And the long-term extension study was designed as you see here. So you'll remember from the design of the ustekinumab study for ulcerative colitis that patients after response were in the maintenance study randomized to either every 8 weeks of 90 milligrams sub-Q, every 12, or placebo sub-Q. And at the conclusion of the maintenance study, they were eligible to continue into a long-term extension. And the long-term extension was the same therapy they had been on. They were able to continue it. So whatever was working, they got to stay on. And you can see here that this goes on and is continuing beyond what we're presenting here today. But what was presented at ACG this year was the 3-year follow-up, basically the week 156 follow-up. So this is a nice summary of the symptomatic remission rates for the drug at the 2 different intervals. You can see here the every 12 weeks compared with every 8 weeks overall this time, and they're essentially interchangeable. You can also appreciate that most patients who were followed out continued to do well with the drug. If you look at symptomatic remission among patients who had achieved clinical remission at week 44, you'll see similar results here as well, meaning that whether you got every 12 or every 8 weeks, patients seem to do well. Clinically, what we'd like to know is who needs every 8 weeks. Previous work looking at the analyses in the maintenance trial, not the long-term extension, but the maintenance trial, suggested that people who had already been on anti-TNF when they went to use Kinemab did better if they were on the every 8-week maintenance intervals. Now, also looking at steroid-free remission, which of course is one of our main goals, you can appreciate one of the main themes of medicines in IBD, which is biologic naive patients do better than biologic failure patients. So overall, on the left, you can see patients doing better than on the right, those who had already failed biologics. But you can see here not much difference overall, but there is a trend here, certainly numerically, for every 8 weeks of use Kinemab in this longer term follow-up to be better than every 12 weeks. And that is the dose that we use, and that's the dose that's labeled in the US. Now looking at, again, at something more objective, you can see median CRP and fecal calprotectin through week 52, 152. And you can appreciate that not only was there clinical and symptomatic remission and steroid-free remission, but these objective measures of the inflammatory control were stable overall this time as well, which you would expect and you would predict given how they did. So with that, I've gotten us through our opening parts, and I'm going to hand it off now to Marla, who's going to present some of the abstracts related to Risenkizumab, one of our IL-23 inhibitors. Marla?
Now that Dave's walked us through our current IL-12/23, now I'm going to be walking you through Risenkizumab. It was quite a busy UEGW and ACG for Risenkizumab, so I'm going to walk you through the induction and the maintenance studies and talk a little bit about the impact of biologic exposure. Next slide, please. So I'm just going to remind you here, there were 2 induction trials with Risenkizumab. One is called Advance and the other one is called Motivate. They were both 12-week trials. The difference really is just in the makeup of the patient population. In Advance, it had both patients who were never exposed to biologics and those exposed to biologics but inadequate responders. And then Motivate was all patients who were what we call bio-IR, which means inadequate responders, so heavily loaded with a more refractory patient population. Both trials, as I noted, were 12 weeks. And in both trials, clinical responders at week 12 were randomized or re-randomized into getting subcutaneous Risenkizumab versus placebo, and I'll show you the Fortify, that's the Fortify study, and that's the maintenance study, and we're going to see a video on that shortly. But what's very interesting in this study, they took those patients who were not responders at 12 weeks and actually re-induced them with a second induction period of 12 weeks. So I will show you that. And if after 24 weeks they were not a responder, you actually discontinued from the program, and if you were a responder, you went into the maintenance. What's important to note is that for many of our patients, the question still always remains, are induction periods appropriate for our more refractory patients? So let me walk you through some of the data. Next slide, please. So this is the co-primary endpoint of just the week 12 of Motivate, which is the entire bio-exposed population. And what you can see here that by the way, in the US, the CDAI was the primary outcome. And outside of the US, it was stool frequency and abdominal pain score, otherwise the PRO2 that we know of. So they were both looking at remission, but slightly through a different index. But both showed that compared to placebo, which is the blue, that both doses of the IV met significance relative to placebo, either the 600, which is in the orange, and the 1200, which is in the blue. Next slide, please. Now, the co-primary was not just clinical, but it was also endoscopic response, which was a decrease in the SC-SED at 12 weeks of at least 50% from baseline. And so what you could see here is that, again, similarly, 600 or 1200, there was no really visual difference between the two of them, but they were both significantly better than placebo. And the deltas, which I always like to reference people when they're looking at slides, it's less about the height of the blue and the orange necessarily, but it's really about contextualized versus placebo response. And here you could see that in this population of even bioexposed, there was an 11% endoscopic response at week 12 in those patients who got placebo. Next slide, please. Then we wanted to look at, because in real world, in practice, this is going to be introduced to us likely in the spring. It will be for Crohn's disease. And the question is going to be, where does this fit relative to our current treatments? And does it matter if a patient has failed just one biologic, or is there a difference, like we've seen with a lot of other therapies, that the more biologics you fail, the less effective the sequence or the subsequent therapy may be? What you're seeing here is, again, referencing it versus placebo. What you're seeing is that when you look at a patient who failed one biologic versus failing more than one biologic, you could see that the placebo rates were very similar, which is good. And you could see that although numerically someone wouldn't look at the graphs and say they're that significantly different, and they were not powered to be different amongst themselves. This is sort of a post-hoc analysis of what this exposure looked like. And you could see here that it was about closer to 50% in those who failed one biologic, and closer somewhere between 35 and 40 if you failed more than one when it came to CDAI. And when it came to stool frequency and abdominal pain, similarly, you could see placebo rates weren't that much different, and you could see that both doses look very similar if you failed one. And then again, a slightly decreased in those who got the lower dose if you failed more than one. So it sort of tells me that it's not like this huge delta between one and none. I mean, failing one or more than one, as much as we see when we say you have not been exposed. That's a much bigger delta. Next slide, please. Here is the endoscopic stratified by failing one versus failing more than one. Here you could start to see again, you're like, wow, the heights of the bars may be a little much. But when you actually look at the delta with the placebo, so referencing it to 15.9 in failing one, and look how much lower your placebo rate is in the trial when it comes to endoscopic response when you failed more than one. So the deltas are a little bit higher in those who just failed one, but you're still talking about delta. You're still talking about a quarter of your patients or so will actually still have endoscopic response if they failed more than one. But there's clearly an advantage endoscopically in the setting of failing just one. Next slide, please. This is also looked at, which is sort of over time and speed, and this was presented by Dave actually at ACG. And what you're starting to see here, because you know timing is everything, right? Speed of response is very popular, and the ability to actually say when do you start to separate curves from placebo in terms of when can I tell my patients they can expect onset of action. Now here you're seeing that already at week 4, there is a p-value significant separation of the royal blue or the darker blue and the orange versus the baby blue, which is the placebo arm. And you could see at all time points, 4, 8, and 12, there was a separation of significance. That was in advance, which are actually patients that were about 50-50 exposed or failures to biologics versus none. And then when you look at Motivate, which is these same they were all exposed, non-responders or inadequate responders to placebo, one, you could see again that there was separation of curves already by week 4. So the question is this the earliest that this drug works, or is this what we should be telling our patients, that that's when we could start to see separation of curves? Next slide, please. Not that we give placebo and try in clinic, but just as an example of when onset of action. That was looking at CDAI. This is looking at the other definition, stool frequency, abdominal pain. And the same story occurs, is that you see p-value significance starting at week 4 in both the mixed population and then the complete biologic sort of inadequate responder population of Motivate. Next slide, please. Similarly, when we look at response, so I just showed you remission. Response, as you know, is always greater numbers than remission in any trial because it's a lower bar that drugs need to hit. But you could see here again that week 4 for both populations of Advance and Motivate, you definitely see already separation of curves from placebo. Next slide. Here is again looking at response, but not with CDAI, but with the outside of the US clinical response criteria, which was stool frequency and abdominal pain. And again, same message, p-value significance already starting at week 4. Then on the next slide, this is where I wanted to introduce you to this concept that, you know, just because clinical trials set the stage that it's 12 weeks or 8 weeks of induction or 10, whatever we have in our trials, doesn't mean that everybody's going to respond by then. And we sort of learned that from tofacitinib, because in the tofacitinib trial, patients after 8 weeks who weren't responsive to 10 twice a day were reinduced for another 8 weeks, or an extended induction, shall we say, with another 8 weeks of 10 twice a day. Well, this was interesting. They took those patients who at week 12 exposure to placebo and the 2 IV doses, those people who were not adequate, met the criteria of response that we've been showing you so far. As I showed you on the design slide, they didn't get discontinued completely. They didn't go into open label extension per se. They had the option to actually get another induction of 12 weeks. But what's very interesting is patients were still blinded, and they either got IV 1200, so another dose of the higher IV dose, or they were actually put on sub-Q. But because it was a double dummy, all patients got sub-Q and all patients got IV. So they didn't know which one of the 3 arms they were getting. So that's essentially what happened. Next slide, please. So this is the result at week 24. So this was the second 12 weeks of either sub-Q or IV. And I find this not as fascinating to say that the IV, you needed another 12 weeks, and you were able to capture actually 62% of patients were now responders. But look at what happens when you still transition to sub-Q. We actually saw that even if you didn't get IV, but you just continued to follow patients out another 12 weeks, we were able to get a significant increase in response to week 24. So this really speaks to the fact that we need to be following our patients a little bit longer and not abandoning drugs like they randomize them in trials where they withdraw at 12 weeks. We were happy to see that they were able to get another set of induction. So this is showing you over time, 12 weeks, which is it starts at 12 weeks, then 4 weeks later, you start to see how it starts to separate out. And what I want to show you is that, again, it looks like there wasn't an advantage of giving another IV induction. So this is good news, so patients can stay out and get sub-Qs and continue out. Next slide. So this is CDI remission, and also remission using the stool frequency and abdominal pain scores. And similarly, it's pretty eye-opening to see that you didn't need an IV. You actually got better effect if you just actually continued with giving the sub-Q right from the time week 12, just like everybody else who went into the maintenance. The only difference is they didn't get placebo in this arm, meaning they didn't get a withdrawal arm. So this is really important for us to use in the clinic when this therapy comes out. Next slide, please. And this is the endoscopic response, again, showing no huge difference across the board between IV and sub-Q. Again, patients were able to get endoscopic response at week 24, which means 6 months of drug. And here's showing you sort of the stability over time. Next slide, please. This is just showing you the treatment emergent adverse events in the second induction, which means they got drug for 24 weeks in total. And what I did want to point out, there is 1 death in the IV group, but actually because safety was for 140 days after the last administration of the study drug, that particular patient actually received infliximab also after they had fistulizing Crohn's disease and then passed. So that was the death that was attributed in the IV group. But again, this was a patient who also got infliximab in those 140 days. Other than that, you're really looking at sort of adverse event profile that is matching what we saw in the first 12 weeks. Next slide, please. All right, so now I'm going to explain the Fortify trial, which I presented here at ACG, and my colleague Mark Ferrante presented at UEGW, and I'm going to show you his video in just a moment, but important to recognize the design of the study. So both induction trials, just like we're classically used to, 2 key induction trials were then fed into and both fed into the Fortify maintenance trial. Responders from week 12 were actually re-randomized. Everybody got drug. So remember, these are patients who got drug in induction, were then re-randomized to 3 arms. One is 360 sub-Q every 8 weeks. The other one is 180 sub-Q, and the third is placebo, which is that withdrawal, or we take drug away and put the patient on placebo. The endpoint was at week 52, which was clinical remission and endoscopic response. So now I'm going to have Mark sort of walk you through the key data points from this trial.
My name is Mark Ferrante. I'm a gastroenterologist at University Hospitals of Leuven. So Fortify was the maintenance study with Risenkizumab, evaluating its efficacy and safety in patients with Crohn's disease. Straightforward study design. Patients who had a response to induction therapy with intravenous Risenkizumab in advanced and moderate were allowed to enter this maintenance study, where there was a re-randomization towards subcutaneous Risenkizumab 360 mg every 8 weeks. Same treatment, but at a lower dose of 180 mg of Risenkizumab, or withdrawal, the so-called placebo arm, where patients only receive placebo subcutaneously every 8 weeks. And you can see that the follow-up was about 1 year, and the co-primary endpoint was again 2 endpoints: clinical remission as well as endoscopic response. So this slide shows you the main endpoints, or the co-primary endpoints, looking into clinical remission and endoscopic response. And you can see that for all of these endpoints, patients who were randomized to Risenkizumab achieved this endpoint more frequently than patients who were randomized to placebo. So for CDI clinical remission, this was the case for both doses, while for the clinical remission based on the period 2, so the stool frequency and the abdominal pain score, this was only significant for the higher dose of 360 mg. You might also notice the quite high placebo response rate if you look to more subjective clinical endpoints. However, it's clear if you look toward the more objective endoscopic response that there is a significant delta between Risenkizumab treated patients and patients who had to stop Risenkizumab. So clearly showing the efficacy of the drug, also looking into more objective endpoints. Of course, also several secondary endpoints were evaluated, but I would like to draw your attention to these 2 very stringent endpoints. First one being endoscopic remission, meaning an SES-CD of maximum 4, and the second one being a CDI deep remission, so the patients who have both CDI clinical remission as well as endoscopic remission. So very stringent endpoints. And you can see that patients who received the high dose maintenance, so Risenkizumab 360 mg subcutaneously every 8 weeks, achieved this stringent endpoint of endoscopic remission up to 40% of the patients, and the combined CDI deeper remission up to 30% of the patients. And these are very, very relevant endpoints, and I'm not aware of any other trials showing this with the drugs that we currently have available. So the conclusions of the trial should be clear that patients who do respond to an IV induction with Risenkizumab, that in those patients, if they continued subcutaneous treatment, that they will maintain clinical remission as well as endoscopic response. The stringent endpoints were very consistent and also showing Risenkizumab dose-response relationship. And I didn't show it, but also the safety aspect of Risenkizumab was confirmed to be very, very good. So in my personal opinion, I think that based on this very nice efficacy as well as safety profile, Risenkizumab clearly has a potential to become a game changer in the treatment of patients with moderate to severe Crohn's disease. Please be aware that in Fortify, 3/4 of the patients already had failed at least one biological therapy. So even in that more refractory patient population, we were able to find these stringent efficacy endpoints, and again, also a very good safety profile. So I really hope that I will have risankizumab in my clinic available soon, not only for the biological failures, but also for the biological naive patients. And with this, I would like to thank you for your attention.
Wonderful. All right, so Dave, now we're going to send it over to Dr. Spencer, who's, oh no, actually, sorry, I'm going to talk about vedolizumab. Vedolizumab in pouchitis, interestingly. So this was presented by Dr. Simon Travis at UEGW, and this was a really interesting study that we wanted to highlight. Next slide, please. This was the EARNEST study, and this was actually a randomized double-blind placebo-controlled study of vedolizumab plus Cipro versus placebo. Here you can see the study design. What I want to highlight for you is part of the design is patients had an endoscopy. They were assessed as having active inflammation. They also had to have a history with at least 1 year prior to randomization with active pouchitis. And they had to have greater than or equal to 3 recurrent episodes within 1 year before that visit. And they needed maintenance, requiring maintenance antibiotic therapy for at least 4 weeks before that baseline. So then they were randomized to either placebo or vedolizumab. Both groups took ciprofloxacin for 4 weeks. There was a small subset of patients in both arms, actually, both placebo and vedo, that were actually on steroids. In order to be deemed a success, they had to be off steroids. They can start weaning at 4 weeks into the trial and had to be off by week 12. So these were sort of the outcomes of the 2 intervention group of placebo versus vedolizumab, and they had an endoscopy at week 34, and their primary endpoint was week 14. Next slide, please. So this is the modified pouch disease activity index remission at week 14 and week 34. And what you can see here, there was a clear efficacy advantage of vedolizumab compared to placebo at both time points, week 14 as well as week 34. You didn't as much get a huge difference in efficacy at the 2 time points, and there was a slight increase in placebo rate as you moved out to week 34. Next slide, please. And here is sustained remission, which means at both time points. And what you can see here is in terms of both the modified pouch disease activity index as well as the actual pouch disease activity index. There's not much distinction between them, but you could see that there's about 1/4 to 1/3 of patients were able to meet both time points of being in remission. Next slide, please. So the idea was that, there have been a couple of publications on the role of vedolizumab for chronic pouch inflammation. So we thought this was really interesting to be able to bring to you the actual placebo-controlled study. So this just added to the literature on the role of vedolizumab in chronic pouchitis. So I will now officially hand it over to Dr. Spencer, who's going to walk us through the next class of therapies.
Hi, so we're going to shift to Janus kinase inhibitors or JAK inhibitors. And David showed you earlier that these oral small molecules act on the JAK-STAT pathway intracellularly, and which also includes TYK2 in that family. Cytokines, you can see here at the top, bind to these receptors on the cell surface. And then you can kind of note the various configurations of the different JAKs and TYK2 here. And once they bind, they lead to successive phosphorylations, which then leads to a change in gene expression, which can often be pro-inflammatory and kind of continuing a pro-inflammatory cascade. So once one of these inhibitors binds here, it can stop that cascade in its track. So if you look at the bottom, I've listed these as actually very selective inhibitors, but they're not 100% selective, any of them. It's all a relative selectiveness. So tofacitinib, which we're going to talk about tonight, is non-selective. The other 2, JAK1 inhibitors, upadacitinib and filgotinib, which we'll also talk about, are really more selective for JAK1. There's 2 newer therapies, ritlecitinib, which is a selective JAK3 and TEC inhibitor, and then brepocitinib, which is a TYK2 and JAK1 inhibitor. And we're going to go through all of these I'm going to start off with something we know, which is tofacitinib, and we'll first talk about post hoc analysis of some patient-reported outcomes, or PROs, and then move on to the long-term extension study, Octave Open. So let me remind you, first of all, what the Octave study was all about. There were two different induction studies, Octave 1 and 2, and they both used tofacitinib 10 milligrams BID and placebo. Responders to this were then re-randomized in Octave Sustain, which was the maintenance trial, into 10 milligrams twice a day, 5 milligrams twice a day, or placebo. And then people who were treatment failures or who completed this Octave Sustain could then be enrolled in Octave Open. Anybody who went in remission received tofacitinib 5 milligrams twice a day. If you weren't in remission, you could get 10 milligrams twice a day, and if you had a flare, you could be escalated to 10 milligrams twice a day. So the PROs, which were this initial post hoc analysis that they looked at, were this rectal bleeding score, where 0 is no blood seen, a stool frequency score, where 0 is normal and 1 is 1 or 2 more stools than normal, and then a partial Mayo score, which we all know, and then an IBDQ remission, which is a quality of life measure where 170 or above is remission. So this is showing you the induction phase and the PROs, and the proportions of patients with no rectal bleeding and normal stool frequency or nearly normal stool frequency. And you can note that most of the patients on tofacitinib had improvements in their rectal bleeding score or stool frequency during induction, much more so than placebo. And then this is the maintenance trial. You can see that they're all starting very similarly at baseline. And then after that re-randomization, those who were on tofacitinib active, either 5 or 10, had a sustained response, unlike those who are on placebo, who you could see dropped here across the way. So again, supporting this robust and sustained response. This is specifically those who were in remission when they went into the open label extension trial and continued on 5 milligrams twice a day. And you can see that in those in the observed part of the study, 95% remained in remission, I can't talk. And then the non-responders, they actually imputed their data by carrying forward their last result, and in that they still had over 50% who were in partial Mayo score remission at month 48. So really a nice durable response. IBDQ remission was very similar, the same, above just above 50% with this intention to treat analysis that had maintained IBDQ remission. So in a sub-analysis of patients who were starting the open label trial in remission, and again, I'll just remind you that they were getting 5 milligrams BID, but they could be escalated. And if they started at 5 BID, they had to wait until month 2 to be escalated to 10 milligrams twice a day. So that specific subgroup starting on 5 milligrams twice a day, where there were 163 participants, a median time on drug of 4 years, up to a maximum of 7 years, and they had repeated endoscopy up to 36 months. This is showing you two different groups, those who were in the maintenance trial at 5 and were maintained on 5, and those who were in the maintenance trial on 10 and were actually de-escalated in the open label extension to 5. And again, it's that same observed versus the intention to treat population. And you can note that they're actually very similar between the two groups. There's not a big difference in those who were de-escalated, and they had a very nice sustained response out to 36 weeks. This is a partial Mayo score remission out to even further, out to 60 months. And patients who received 5 and 10 milligrams in sustain, again, had very similar outcomes. You can see their graphs look very similar, with a very long sustained remission in some. Finally, the patients who received 5 milligrams twice a day in the open label extension but had a flare and had to go up to 10 milligrams twice a day, which was about a quarter of the patients, and about half of those were on 10 milligrams and then were taken down to 5 and then had to go back up to 10. But if you look at this, when they de-escalated, they were able to recapture a pretty good response by the 3rd month. And this is just a good data point to show, especially when we're really considering all de-escalating our patients from that higher dose for safety reasons, that if we de-escalate, they lose response, and we re-escalate, we can recapture that response in a very large majority in a relatively short time period. This, again, just in that sort of safety vein, this is an analysis looking just at those on 5 milligrams twice a day, which we've seen time and again is safer. And this is continuing that same story in the open label extension study. So when we look in those only on 5 milligrams twice a day with 643 person years of follow-up time, there are signals for worsening UC and nasopharyngitis, like I have now, and herpes zoster, as has been kind of a common theme. The herpes zoster, though, it might warrant a discussion with your patient about inactive vaccines. But the reassuring point about this data is that there were 0 deaths, there were 0 DVTs, and there were 0 PEs in those who are on 5 milligrams twice a day. So next, that turns me over to upadacitinib, which, as I told you before, is a selective JAK1 inhibitor. And I'm actually going to let Remo Paniccioni tell you more about this. So give me 1 second.
Hello, everyone. I'm Remo Paniccioni, Professor of Medicine and Director of the IBD Clinic at the University of Calgary. And it's my pleasure to present the data from the upadacitinib development program in moderate to severe ulcerative colitis. As you know, upadacitinib is a selective JAK1 inhibitor that's being looked at in a variety of immune-mediated diseases, including ulcerative colitis. The phase 3 trial design is in front of you. It consisted of 2 identical induction studies called UACHIEVE and UACCOMPLISHED, where patients with moderate to severe ulcerative colitis were randomized either to receive upadacitinib 45 milligrams once daily or placebo. The patients were randomized in a 2-to-1 fashion, and the primary endpoint was clinical remission by the adapted Mayo score at week 8. Patients who responded during the induction study were eligible for the maintenance phase of the program, in which patients were randomized in a 1-to-1-to-1 fashion to either 2 doses of upadacitinib, 35 milligrams once daily or 15 milligrams once daily, or to placebo, with the primary endpoint once again being clinical remission by the adapted Mayo score at week 52. So just to give you an idea of the type of patients that came into this trial with moderate to severe ulcerative colitis, you can see what we're highlighting here is that approximately half of the patients had been exposed to biologic therapy, with a number of the patients being exposed to more than 1 biologic therapy. And if we think about the adapted Mayo score and severity, about 40% of the patients had an adapted Mayo score of greater than 7, which is more on the severe end of the spectrum. Now, if we look at the results on the left-hand side here, we're showing the results in the induction studies, both UACHIEVE and UACCOMPLISH. And you can see for the primary endpoint, 26% and 33% in the 2 studies, with deltas of 22% and 29% over placebo. These are highly statistically significant. If we look in the patients who responded or randomized into the 2 doses in the maintenance, you can see that the clinical remission was 42% in the 15 milligram once daily dosing, and it was 52% in the 30 milligram once daily dosing, giving us deltas of 30 and 40% respectively, and again, highly statistically significant. What was noted in this program is that patients who did respond during the induction study responded quite quickly with statistically significant differences over placebo in a pre-specified analysis as early as week 2. And in the maintenance therapy, I already showed you the clinical remission, the primary endpoint on the far left-hand side, but these are a host of ranked secondary endpoints, including endoscopic improvement, maintenance of clinical remission, which means you're in remission at week 8 and then week 52, steroid-free remission, and all the way over to sort of the endoscopic and more objective measures, including a new measure, histoendoscopic mucosal improvement on the far right-hand side here, where you can see in the 30 milligram dosing group, almost half of the patients had a Mayo endoscopy score of 0 or 1 and were in histological remission. So very robust outcomes. As far as safety, there are some concerns with safety with the JAK class based on our experience with tofacitinib and the oral surveillance. The most common AEs were elevations in the CK amongst the upadacitinib groups, but overall it was quite well tolerated. There was a signal for herpes zoster, which we've seen within the JAK class, and there were 2 cases of venous thromboembolism, which in the efficacy group analysis. So what are the potential implications of these data to clinical practice, which is probably the most important questions? Well, as I showed you, for induction and maintenance, upadacitinib had significantly greater efficacy compared to placebo for all the primary and secondary endpoints over a year. These include impressive effect sizes in clinical, endoscopic, and histological evaluations. I think selective JAK inhibition has the ability to transform the way we do treat moderate to severe ulcerative colitis. It's rapid in its effect, it's highly effective overall, it's oral, it's non-immunogenic, and then therefore it gives us a long-term option. Ultimately, positioning will be decided by healthcare providers and their patients, and perhaps by regulatory agencies. Thank you for allowing me to present these data, and I wish you a great meeting.
That was a really great talk from Dr. Panaccione, and now we're going to be discussing filgotinib, another JAK1 selective inhibitor.
Hello, I'm Iris Dotan from the Rabin Medical Center in Petah Tikva, Israel. And it's a great pleasure to present to you an abstract that we recently presented during the last UEGW. So the abstract we presented was entitled Efficacy of Filgotinib in Patients with Ulcerative Colitis by Line of Therapy in the Phase 2b/3 Selection Trial. And I'm presenting on behalf of all authors. There is a high proportion of patients with ulcerative colitis who do not respond to treatment, or they lose response over time. Thus, many of them switch between different therapies, which have different mechanisms of action. And recently, we're fortunate to have new mechanisms of action, specifically the Janus kinase inhibitors, and filgotinib is a once-daily oral Janus kinase 1 preferential inhibitor. So in the Phase 2b/3 Selection Trial that was recently published, filgotinib 200 milligrams was well tolerated and efficacious in patients with ulcerative colitis in inducing and maintaining remission versus placebo. So in these post-hoc analysis that we are presenting now, we aimed actually to assess the efficacy of filgotinib in inducing and maintaining clinical remission and Mayo Clinic score response in patients who are biologic naive and biologic experienced. And in the biologic experience group, we wanted to see what will be the effect in patients who failed 1 or 2 or more biologics, or 1 or 2 mechanisms of action, which will be anti-TNF alpha inhibitors and vedolizumab. So as you all remember, the Selection 2b/3 double-blind randomized placebo-controlled trial included patients who were adults with moderately to severely active ulcerative colitis that had evidence of ulcerative colitis by endoscopy and histopathology for over 6 months. So the diagnosis had to be at least 6 months before enrollment. And their, of course, clinical activity was assessed by the Mayo score and total Mayo Clinic score of 6 to 12 points, including Mayo endoscopic subscore of 2 or more, rectal bleeding subscore of 1 or more, stool frequency score of 1 or more, and physician global assessment of 2 or more. Now, this is the study design, and patients were included in 2 induction studies and a maintenance study. So the induction studies were for 10 weeks. You can see them here, where patients were enrolled on a 2-to-2-to-1 basis to receive either filgotinib 200 milligrams once daily, or filgotinib 100 milligrams once daily, or placebo once daily, and they were included as a biologic naive or biologic experienced patients, and that was study induction A and B respectively. So after 10 weeks of treatment, patients who were responders, whether they responded to active drug or to placebo, they were entitled to be included in a maintenance study until week 58. Now, the eligibility, as we said, for the maintenance study was completion of induction A or B in clinical remission or Mayo Clinic score response, and you can see the definitions of clinical remission and Mayo Clinic score response in your slide. So this is an important outcome slide. This is the proportion of patients in clinical remission at week 10. As you can see on your left-hand side, filgotinib 200 milligrams was effective in inducing clinical remission at week 10 in patients who are biologic naive and biologic experienced. On your right-hand side, you see the biologic experienced patients and here a larger treatment effect was observed in patients with failure of one biologic or one mechanisms of action than in those with failure of multiple biologics or multiple mechanisms of action. Similarly, the proportions of patients in Mayo Clinic score response at week 10 are presented here. And here what you can see, again, on your left-hand side, you can see that filgotinib 200 milligrams was efficacious in inducing Mayo Clinic score response at week 10 in biologic naive and biologic experienced patients. And in the biologic experienced patients, in patients with failure of one or two or more biologics or one or two mechanisms of action. When we're moving to the maintenance outcomes, to the week 58 clinical remission, there were higher proportions of patients that were biologic naive or biologic experienced responders and biologic experienced responders with failure of two or more biologics or two mechanisms of action that were treated with maintenance filgotinib 200 milligrams versus placebo that were in clinical remission at week 58. And here we are showing the Mayo Clinic score response at week 58. Here we see that higher proportion of responders in all patient groups and subgroups that were treated with maintenance filgotinib 200 milligrams versus placebo were in Mayo Clinic score response at week 58. So to summarize, we can see that higher proportion of biologic naive and experienced patients with moderately to severely active ulcerative colitis that were treated with filgotinib 200 milligrams versus placebo achieved clinical remission and Mayo Clinic score response at weeks 10 and 58. Now, the induction results that we showed you for 10 weeks suggested that filgotinib 200 milligrams has a numerically greater treatment effect in biologic naive patients than in patients in other treatment groups, and in patients who failed only one biologic or mechanism of action than in those who had experienced failure of multiple biologics. The week 58 data suggests that filgotinib 200 milligrams, but not 100 milligram maintenance therapy, benefited patients in all treatment history groups and subgroups, although the data should be interpreted with caution because there was a low patient number included in the maintenance study.
So a really great presentation from Dr. Dotan. So now I'm going to turn to kind of the same question Marla was talking about before, which is, are we giving too short of an induction phase, but this time for filgotinib? So with this is looking specifically at those in the selection trial who did not respond to induction and entered the long-term extension trial. And this was both the bio-naive and the bio-experienced group. But you can see here that even those who were on 200 milligrams, continued on 200 milligrams, had no changes, they continued to have improvement up to week 12. If we move on to the next slide, you can see that this continues and is a little bit even kind of clearer here, where those in partial Mayo score remission, partial Mayo score response, they do improve in the long-term extension trial. Kind of you can see continued improvements up until week 12 across the board in all treatment groups. And so it's just another kind of commentary on perhaps there are some, in this case, both bio-naive and bio-experienced who really might benefit from a little bit longer of an induction phase. So next, we always have, one of the benefits of JAK inhibitors is that they're very fast, and there's a benefit to them that we can really reduce corticosteroid use. So they did an analysis of selection looking to see if filgotinib actually did reduce corticosteroid use. They considered people corticosteroid free if they had no systemic or localized corticosteroid use, and then they did cut points of none for 1 month, 3 months, 6 months, 8 months. Clinical remission they defined here as an endoscopic subscore less than or equal to 1, and rectal bleeding of no rectal bleeding, and an improved stool frequency to either normal or 1 or 2 above normal. And in this figure, you can see that those who received filgotinib 200 milligrams rather than those who were changed to placebo in their maintenance phase had a markedly improved rate of corticosteroid-free remission. You can see the proportions are significantly higher across the board. And you can also see that there was a large percentage who were in corticosteroid-free remission. So 6 months off of steroids, 27% of the patients in remission. So then this is looking at actually the dose of corticosteroids. This is a prednisone equivalent dose. And those on filgotinib, again, compared to placebo, filgotinib is here in the green, were on a lower dose as well across the board. And finally, I was showing you before the data from patients who entered the maintenance trial on corticosteroids, and so what their experience was like. And this is actually everyone in the selection trial who went into the maintenance study. And you can see that in those who were in remission, almost all of them were actually in at least 6 months of corticosteroid-free remission, so 93% here. So really a large majority. And then again, another kind of topic Marla touched upon was that the patients really want to know the speed and where the curves start to separate. And this gets to that question. So for filgotinib, the curves really start to separate as early as week 2. You can see here in the 200 milligram group at week 2, it was significantly different from placebo. And even the 100 milligram group also started to separate as well at week 4 for partial Mayo score remission, and both the biologic naive and biologic experienced. This is in the maintenance study where they look to see how do you sustain it, especially in those who were switched to placebo. Can they sustain remission off of drug? And you can see that those who were maintained on filgotinib 200 milligrams really had a very nice sustained response over time, which was very different from those who were switched to placebo. It's most striking, I think, at this week 58 time point, where you can see that those who were on placebo were switched from filgotinib 200 milligrams to placebo were less than half as likely to be in partial Mayo score remission compared to the participants who were on filgotinib still. And then finally, we always just like to know, is this clinical score, the Mayo score, impactful to a patient? Does it actually impact their quality of life? And they did an interesting thing, which is they looked at the concordance of the IBDQ, the quality of life measure, and the partial Mayo score, and they actually found quite a good concordance between the two. So the kappa statistic, I'll give you the quickest of quick primers, which is that if you have 0.41 to 0.6, you have moderate concordance between the two. If you have 0.6 to 0.8, you have actually very good concordance. And then if you're 0.8 to 1, you have near perfect concordance. So you can see at week 10, they had very good concordance. And then at week 58, it was even more so improved. Not quite yet at the near perfect, but still pretty good. So again, just kind of telling you the story that filgotinib does make an impact both on their partial Mayo score and their quality of life. And then finally, I'm going to turn to the last two, which are always hard for me to pronounce, but they're ritlecitinib, which is that JAK3 TEC inhibitor, and then brepocitinib, which is a TYK2 JAK1 inhibitor. And they looked at these actually together. So it was done in an umbrella study, and an umbrella study is when you look at multiple drugs for the same indication. And the indication for this vibrato study was ulcerative colitis, moderate to severe, with a total Mayo score of greater than or equal to 6 at the beginning. And they randomized them into one of these drugs and then into one of 3 dosing categories or placebo, followed them for an 8-week induction period, 24-week maintenance period, and looked at remission and endoscopic improvement. They had 319 total participants, and you can see their baseline kind of characteristics here. I think most importantly, about half were biologic naive, and then a little less than half were on steroids at baseline. And you can see that in the two higher groups in both medications, so that's this green and this yellow and purple, for both remission and endoscopic improvement, there was a difference. There was a significant difference from placebo. So some preliminary efficacy data. And then, of course, with all of the JAKs, we always want to know, are they safe? So with this initial small study, they did have very few adverse events. The number of treatment emergent adverse events were a little bit higher than placebo, but were very similar and very low for both drugs. There mainly were infections was one of the primary events that was seen. And now it brings us to the end of our JAK inhibitors, and I'm going to pass it off to Dr. Dalal now.
We'll switch gears then to Sphingosine 1 phosphate receptor modulators. Can you advance? So Sphingosine 1 phosphate receptor modulators, there are 5 receptors, sphingosine P1 through 5, that are listed here. We're going to focus our discussion today on Ozanamat, which targets S1P1 and S1P5. You can see here that those are expressed, S1P1 is expressed in B cells, T cells, dendritic cells, endothelium, and cardiac tissue, which brings up our monitoring for bradycardia when patients are started on the drug. And S1P5 is expressed in natural killer cells, endothelial cells, and oligodendrocytes. So this is where Ozanamat is targeted towards S1P1 and S1P5, and it's blocking lymphocytes from exiting lymphoid tissue. So it's blocking them from getting into the system and going to sites of inflammation. Next slide. So we're going to go through the True North trial study design. This was recently published in full in the New England Journal of Medicine at the end of September. And so this study was divided into 2 cohorts. Cohort 1 was randomized 2-to-1 amongst patients that received Ozanamat versus those that received placebo in a double-blind fashion. Cohort 2 received open-label Ozanamat. The induction time point was at week 10, and the primary endpoint measured was clinical remission. Amongst those that achieved clinical remission at week 10, those that were responders to placebo continued on placebo. Those that responded to drug were re-randomized to either get Ozanamat placebo or Ozanamat. If patients relapsed, they could go into open label extension. We're going to look at a post hoc analysis today, looking at the biologic naive versus biologic experienced patients. Next slide. So medication use at baseline during induction. Notably, patients in the study, there were biologic naive patients. There were patients that had been on 1 prior biologic or 2 prior biologics. Most of the prior biologics were anti-TNF medications or anti-integrins. There were few in the study that were on Kinemab. And in this analysis, they did not look at patients that had been on prior JAK inhibitors. Notably, the patients that were on 2 prior biologics did have a higher percentage of patients that were on corticosteroids. You can see across the board that patients that had 2 prior biologics, about 60% of them were on corticosteroids, as opposed to those that were bio-naive or had previously been on 1 biologic, whereas that was only about 27% of the study population that were still on steroids. Next. So at week 10, the induction primary endpoint, we can see that Ozanamat, colored in green here, met its primary endpoint of clinical remission. So clinical remission in this study was based on a 3-component Mayo score, which is a rectal bleeding score of 0, a stool frequency score of less than 1, and a greater than 1 point reduction from baseline, and a mucosal endoscopy subscore of less than 1 without friability. So Ozanamat did meet its endpoint at week 10, and looking at the secondary endpoints of clinical response, endoscopic improvement, and mucosal healing, it also met those endpoints at induction. Moving on then. to week 52, maintenance. At maintenance, Ozanamat once again met its primary endpoint of clinical remission, as well as secondary endpoints of clinical response, endoscopic improvement, maintenance of remission, so maintaining remission that those achieved at week 10, maintaining it out to week 52, corticosteroid-free remission, which was off steroids for at least 12 weeks at the 52-week endpoint, mucosal healing, and durable remission. We'll then move to the next slide and look by prior biologic use. So here we can see a comparison at the primary endpoint of clinical remission between the bio-naive patients as well as those on 1 biologic and 2 biologics. You can see that those that had previously been on 1 biologic looked more similar to the bio-naive patients in their response. They had a numerically higher response than those that had been on 2 biologics. And you'll recall that when we looked at the demographic data, the 2 biologic patients also tended to have higher steroid use, perhaps reflecting a sicker, more refractory population. Amongst clinical response, we can see a sort of similar pattern where the bio-naive patients met the endpoint of clinical response, and the patients that had 1 prior biologic had sort of numerically higher responses than those that had previously been on 2 biologics. So again, sort of that theme that we've seen throughout the evening, that the bio-naive patients tended to do better, and the sort of more they had been through, the worse they did. Induction efficacy outcomes at week 10 by prior biologic use, looking at those secondary outcomes in the study, endoscopic improvement in mucosal healing. We sort of see a very similar pattern to the ones we saw previously, where the bio-naive patients did the best, followed by 1 biologic and then 2. When we then move out a little further to maintenance, so that 52-week endpoint, we see that things improve. Given a little bit more time, the patients that had been previously on 1 biologic or 2 biologics start to look more like the bio-naive patients, again, for the primary endpoint of clinical response as well as secondary endpoint of, primary endpoint of clinical remission as well as clinical response. And again, we see this in amongst the other endpoints, endoscopic improvement and mucosal healing. In endoscopic improvement, we still do see that the 2 biologic patients do lag behind those that have been on 1 biologic or bio-naive, which look very similar by the time we get to 52 weeks. We see a similar pattern for mucosal healing, where patients that had been experienced with 1 biologic look similar to the bio-naive patients, but the patients with 2 prior biologics do lag behind. In terms of safety, the most common adverse events, both in the induction phase as well as the maintenance phase, were anemia, nasopharyngitis, and headache. The serious events, you see exacerbations, this was low, and severe events was very low as well. So overall, reassuring safety signals. Okay, we're going to switch gears then to a new mechanism and selective upregulation of an anti-inflammatory microRNA, Micro Rna 124. This is a novel therapeutic called ABX464. We're going to look at the phase 2b study of this medication. So just a quick review of microRNA is a small non-coding RNA that binds to messenger RNA and can prevent translation. So it works sort of a post-transcriptional regulation. This drug upregulates microRNA 124 and has anti-inflammatory effects. It's also been studied in HIV and RA. In this phase 2b study, the patients were randomized into 4 groups. There were 3 study doses of the medication, 25 milligrams, 50, and 100, and placebo. Patients were screened with endoscopy at baseline, and then at the end of week 8, as well as week 16. And then there was open label extension at the 50 milligram dose. Moving on. So the baseline characteristics of the patients, many of the patients had a modified Mayo score of 7 to 9. And you can see the endoscopic subscore of 3 was in about 65 to 75% of the patients across the doses. So this was an inflamed patient population. You can see their calprotectins there as well, are reflective of that. In terms of prior drug exposure, they did include patients that had been exposed to biologics, anti-TNF or vedolizumab, as well as tofacitinib in the study. And corticosteroid use was similar amongst the patient groups. Next. So the top line week 8 efficacy results, the primary endpoint was a mean change from baseline in the modified Mayo score. So you can see here on the left, all patients at the doses of 25 milligram or 50 milligram, we can see that both of those groups had a change from baseline of about 3, whereas 100 milligrams was just a little bit less than that. Amongst the biorefractory patients, we actually see fairly similar results with a significant mean change from baseline in the modified Mayo score. Moving on, secondary endpoints of clinical remission amongst all patients on the left there, we can see that the lowest dose of 25 milligrams met its endpoint. Clinical remission amongst the biorefractory patients followed sort of a similar pattern, though sort of numerically lower. Moving on, other secondary endpoints, including secondary clinical response, as well as endoscopic improvement. Again, we saw encouraging results at the studied doses. Clinical secondary endpoints of change in fecal calprotectin. You can see that there was a significant change in calprotectin from baseline, and as well as a change in the Robarts histopathology index as well. So they looked at several objective markers of inflammation as well that did improve. So the onset of action, here we can see the placebo in sort of the dark blue at the top and the study doses of medication below. We can see that at day 29, we really see separation of those curves of all 3 doses studied versus placebo. And sort of that trend kind of continues out to day 57. So again, looking at onset of action, you can see that the curves really start to separate around day 8, so again, a quick acting oral medication. Safety data was reassuring. The sort of most common adverse effect was headache, which occurred in the first few days of taking the medication and then resolved afterwards. Other noted adverse events were nausea and vomiting.
All right, well, I want to thank both Sushila and Lizzie for their outstanding presentations. And I have one more abstract to share with the group, which we thought was very interesting, and then we'll open it up for Q&A. And if you haven't already typed your questions into the dashboard, please do so. So this abstract was on autologous stem cell transplantation for Crohn's disease. And I'm sure that many of you have heard about this and thought about it before. And there have been previous efforts to study it, but we have been challenged in getting good data and understanding whether it was safe. The abstract was presented by James Lindsay from the UK. Not sure if it's visible. I'm going to make sure you can see my slides. There you go. The name of the study was ASTIC Light. It was a randomized controlled trial of autologous stem cell transplantation for Crohn's. These were patients who had active Crohn's by endoscopy, who had had a non-response to at least 2 classes of biologics, and in whom surgery was not an appropriate option. They had to be well nourished. In other words, they couldn't be otherwise malnourished and have other comorbidities that would put them at higher risk for complications. They also had to meet screening criteria for bone marrow transplant assessment, which is a separate list, as you might imagine, and the usual exclusion criteria. Patients were randomized to either what was called standard of care with any licensed therapy, so whatever was available or whatever the clinician could provide, or the actual hematopoietic stem cell transplantation with a modified protocol that they called LIGHT, with follow-up as you see here, and then ongoing clinical care and long-term follow-up. You can see that they had MRI built in, as well as some additional biomarkers and scopes to assess these patients. They randomized 66 patients. The plan was for 66 patients in the hematopoietic stem cell transplant arm and 33 patients in the standard of care arm. But actually the trial got discontinued after only 34 patients total were included because of safety concerns. The way this worked is that, as you'll recall from your days on oncology and hematology, there's a mobilization phase where you are recruiting the patient's own marrow and stem cells, which are then harvested. And then there's the conditioning phase where you essentially knock out their marrow and shut off their immune system, and then rescue them with their own marrow, which is how this works. And you can see the protocol there that I don't need to go into all those details. The primary outcome was defined as a centrally read endoscopy score of 0, meaning no ulcers, as well as obviously the patient survived and didn't need surgery. And you can see, looking at the primary outcome, and remember the study was stopped because of adverse events that I'll get to, but you can see that 3 of the patients who were randomized to the stem cell transplant achieved that primary outcome, while 0 who got the usual care obtained that outcome. And you can also see an imputation of patients who were missing data. And then we had 1 more patient who actually achieved the outcome with the stem cell transplant. So there were some patients who responded to this and who did okay, at least initially. The other outcomes that they looked at were clinical remission, steroid-free clinical remission, and a complete endoscopic remission. And you can see the comparison here, where clearly this particular chemotherapy and bone marrow transplantation approach worked from a clinical point of view. You can also see those continuous outcomes of endoscopic scores. But here's the challenge. There were some significant serious adverse events in the mobilization phase, but mostly in the conditioning phase, which is when they had their marrow given back to them, the stem cells, and then in follow-up as well. And there were much less of these serious adverse events in the usual care arm. You can see the total numbers listed there, and it was obviously significant. And you can break it down into a variety of different disorders that were of concern, including general disorders related to administration, but infections and infestations, as well as blood and lymphatic system disorders. And the reason the study was discontinued is actually that there were several patients who had substantially significant adverse events, and 2 died. You can see here 1 patient developed renal failure due to a thrombotic microangiopathy and is requiring dialysis, and 2 patients died, 1 from pulmonary hypertension due to pulmonary VOD, and 1 who had respiratory failure after their transplant. So this was obviously something that had clinical efficacy, but the safety is why it was discontinued and clearly is not going to move forward in its current format. So we thought this was of interest. It comes up occasionally as an option, or at least is discussed, and certainly there's plenty on the internet about it. But obviously these data show us that this is not ready to be used otherwise. So we've heard from our other faculty tonight. I'm going to ask them to turn their cameras back on. You've learned about some long-term extension data on our existing therapies. You've seen the impact of IBD on key patient-reported outcomes, and we had some unique ways to think about those tonight. We saw a randomized study of vedolizumab in chronic pouch inflammation, so that's nice to see. You've seen the impact of biologic failures to inform sequencing of our S1P receptor modulators, induction and maintenance data for our specific IL-23 and selective JAK1 inhibitors, which we are expecting in the next year, hopefully, and some additional novel agents and novel mechanisms of action, including the hematopoietic stem cell transplant trial. And now I'm going to actually open it up for some questions from our audience, and thank everyone for being here with us tonight for this program, and thank, of course, James Lindsay and Peter Irving for their contributions as well. I'll be reviewing the questions and moderating a bit with my faculty colleagues, but I do want to remind you that you're going to receive an evaluation in your email, the same place where you got the link for tonight's program, and we hope you'll take a moment to fill that out so that we can continue to seek grants in the future as well as improve this program. So I'll start with a question to Marla. Marla, there were a couple of our colleagues who wanted to know, in the Risenkizumab studies, were there patients who had already been on Kinemab? And if so, how did they do when they received Risenkizumab?
Great. Yes, actually, at the beginning, they were not in a trial, and then there was an amendment to cap it at 10% of patients included could be ustekinumab failures. And we're still waiting to see that data, how it looks, as to whether or not there was an added benefit. I would say that one of the things that may distinguish the reason why it may work in ustekinumab failures, it may have to do with the dosing. Because part of the question has always been with ustekinumab, have we optimized the dose, right? Are we really we need a lot of patients who need it more often potentially, whether 90 is really the right dose. And I think what we saw is that we're finally getting the dosing right of biologics, which makes, of course, my heart sing, that we're actually optimizing biologics. And you'll see the same from the other IL-23s, by the way, that it was very much being optimized compared to everything we're used to. So stay tuned for that data.
Okay, maybe for our next best of program, we'll have it.
Yep.
Okay, good. Lizzie, great job tonight. There's a couple questions about JAK inhibitors that I wanted to throw your way. Is the venous thromboembolic complication reported in the phase 4 study of tofacitinib something that we're seeing across the trials with the other JAKs, or is it too soon to know?
Well, some of them it's too soon to know. Like the last two that I presented to you, it's early days. Although if you look at the alopecia and rheumatoid arthritis data, they actually haven't seen it there. So no, we're not quite seeing it as the same. So there probably is some benefit to that selective JAK1 inhibition. So looking at those JAK1 and then the JAK3 and TYK2.
I would like to add, I don't want everyone to get nutty around this venothromboembolic, because even in the TOFA Octave programs, looking at long-term extension, there were, I believe, now 6 total cases. So what we're seeing and there was one, and it was PE, I think 5, and 1 was a DVT, but I want to make clear that copying and pasting, this is what we're struggling with for everybody who uses this therapy, and it's going to be a problem when upadacitinib comes out, hopefully in the spring as well. We're going to be sort of beholden to this rheumatoid arthritis data, applying to a very different patient population, different BMIs, different age, different smoking rates, and we really just have to be able to be cautious around over-interpreting rheumatoid arthritis data in a population that is much younger and very different. So I had no heart condition to, no prerequisite of cardiovascular risk. So I do want to be clear that it's not that I don't believe that there's something to this, but we should be choosing therapies wisely for patients who need these kind of JAK inhibitors and not shy away because of the safety from an RA. I don't know, Dave, I think you and I echo that concept because of the utility of this class, and we're going to see that with UPA when it comes out in UC. I mean, the data is quite striking.
Yeah, I don't want to rehash. I agree, as always, with Marla, but I'll add that in the phase 4 study in those older RA patients with pre-existing cardiovascular disease, everyone was on methotrexate with TOFA. So whether they got TOFA 5, TOFA 10, or the anti-TNF arm, they all also got methotrexate. This is not the way we use the drug in ulcerative colitis, and in the real world experience, as well as in other analyses of what we can get our hands on, and our experience at the University of Chicago, which is now approaching 300 patients, we thankfully have not seen this as a recurring issue. So I think obviously we want to be careful and thoughtful, and we know that colitis is a risk, and Crohn's, when it's active, can be a risk for thromboembolic problems, but we're not yet convinced that this exists in our patient population. A question for Sushila about the S1Ps, just in terms of experience with Ozanamat and liver function elevation. Is this something that we in general need to worry about, or does it get better over time? There's a question about whether you stop the therapy and wait for it to go down, or you just keep treating.
I think you can probably watch it a little bit over time.
Yeah. I agree with that as well. In the MS experience, continuing therapy, it's interesting the enzymes would come down. So I think that the liver gets ramped up with the drug when it's starting to metabolize, but then it calms down. So totally agree with that as well. Another question from one of our colleagues is regarding the potential of drug interactions and dietary interactions with Ozanamat. So other than the usual MAOIs, which I still in my entire career haven't seen someone who's actually on one of those drugs, are there other common drugs that we're trying to avoid or not using when someone's going to be receiving Ozanamat? And maybe I'll just open up to the panel, Marla or Lizzie, if you want to comment as well, and I can throw my 2 cents in. There was some question early on about whether we couldn't use SSRIs with Ozanamat, and in fact, that's now been looked at across the MS population and with some more in-depth work, and it doesn't seem to result in any significant complications, so we haven't been too worried about that. But obviously it's something we want to know more about since we have many patients with IBD who are on those agents. Marla?
It's very timely, yeah, very timely, because I just asked our pharmacist yesterday in the hallway, and I said, what are you telling patients about tyramine? And she says, do you know how much cheese they'd have to eat to actually hit 150 grams or whatever of tyramine? They would be basically eating cheese all day. So
yeah, but you know, we're in Chicago, so that's possible.
Oh, that's true. But in the end, New Yorkers at least, it didn't look like we'd ever be reaching that level of tyramine intake.
There. You guys don't know real cheese.
That's true. So that was interesting because I had another family member message me on my chart saying, after Thanksgiving, we're going to start it because I don't want them to eat too much tyramine or something. So anyways, yes, it is a common question, but right now it doesn't look like we're telling people to avoid, regular diet.
Yeah, and we certainly don't want to minimize this, Rebecca, but thank you for the question. But so far it hasn't been an issue, and our pharmacist had a similar comment to the Sinai pharmacist. That was actually all the questions we had tonight, guys. And so just to our loyal listeners who are still with us tonight, we thank you. We wish you happy holidays, happy Hanukkah. Tonight's the 3rd night. And also, if you have colleagues who might find this of interest, tell them we're doing it again on Thursday. They can join us then and hear it live. And the same faculty and the same slides. But we are grateful that you joined us tonight, and we hope to see you in person at an upcoming meeting, whether it's AIBD or the Crohn's and Colitis Congress or all the way out to DDW here in the US. We look forward to that. So stay safe, everybody. Happy holidays, and thank you.
Thank you, everybody. Good night.